And without further ado, I would like to introduce the man, the myth, the legend, Dr. Lonnie Zwaigenbaum, to go in with his presentation.
Thanks very much, Lori. I am blushing. Thanks for a really kind introduction. Thank you, everyone, for being here on a Friday morning. So really pleased to have a chance to talk about this topic. So I'll just put my slides on screen and get started. Oops. There we go. Okay, so I'm really pleased to have a chance to talk about ECHO today. So ECHO stands for Extension of Community Health Outcomes. It is a way of connecting among professionals to develop a community of practice and together learn how to deliver better care and to bring care outside of the specialty centers into the community. Just briefly, we're fortunate to have support for our research, not specifically for ECHO, but other research at the research center, but no industry funding. And I guess the other disclosure is just to reflect on kind of my professional roles. So I work here as a clinician. As Lori had said, I'm a developmental pediatrician. I have the pleasure of working with many of you in many roles, both clinically and for some of you actually within ECHO. So really interested in your thoughts, sort of how the research sort of meshes with your own personal experience with this educational model and where we could be going with this in the Edmonton region and in Alberta. I also have an administrative role as the clinical department head for pediatrics, and it's been an interesting challenge, sort of juggling sort of all the responsibilities associated with it. But one of the joys has been having the chance to work with other specialists in the department, as well as general and community pediatricians, and to think particularly in respect to supporting autistic children and their families, how we can be working together more in partnership, and how do we move beyond our traditional roles to be really supporting one another in maximizing our scope of practice and the impact that we can have. So just to start, this is baby Lonnie in first year medical school with my anatomy group before I may have even heard the word autism. And you know, I am part of a cohort of health professionals that trained in the 80s, and no matter how much we learned, our sort of initial impressions around autism are probably shaped by those initial experiences and what the perspectives on autism were at that time. So in the 80s and 90s, autism was viewed as a rare condition. Our colleagues, Susan Bryson and Isabel Smith, actually conducted the first population-based study of rates of autism in Nova Scotia and came up with a rate of 1 in 1,000, which at the time was actually a fair bit higher than people had perceived. And I do recall, and I think I've told the story before, of being a first-year resident on the pediatric ward in Kingston and seeing a child who wasn't making eye contact and wasn't verbal, and being pulled aside by the supervising pediatrician and being told that, you know, that child had autism and that I really should take some time to meet later in the day with him and his mom, because it was a rare condition and it might be the only child with autism that I would see in my career. So clearly that hasn't played out that way. It's remarkable that for a condition that has a rate of about 2% in the general population now, that the perception as recent as that would be that it's such a rare condition. Autistic children generally receive care within specialty clinics. Primary care physicians and community pediatricians had a somewhat more limited role in supporting healthcare, but I think tended to make referrals into the specialists because of uncertainty about how to provide effective care. In general, autism was seen as a diagnosis to be treated with a focus on behavioral features and really sort of thinking about how to reduce those features and with the goal of perhaps helping people be less autistic. And there's no question that there was a focus on early childhood. And just as a caveat, I'm going to comment on our perspectives now in 2024, but I think it's a bit of a continuum, and I think these views are still not uncommon among practicing physicians. So certainly at that time, there was a bit of an ivory tower approach. There were specialty clinics where children with autism were both diagnosed and also to some extent received their health care. And the primary care community had a less significant role and really didn't work, didn't receive much support from the specialists. The specialists largely worked in isolation. Fast forward, the rates are about 2% now based on a StatsCan survey from a couple of years ago. That's a huge jump from 1 in 1,000 to 1 in 50. There's good data on training and people working in practice, and there's no question that the number of specialists has not kept pace with the increased rates of autism. There's also a recognition of broader healthcare needs. Thinking about autism not as a diagnosis exclusively, but rather as a population of Canadians that are in need of good healthcare. Access to supports and services rests on accurate diagnosis, so there's need for capacity there. Autistic people have the same range of healthcare needs, physical health and emotional health, and the broader determinants of health likely apply as well. So it's important to be thinking about how that healthcare can be delivered in the community. And clearly, children with autism grow up to be adults with autism or autistic adults who continue to have those healthcare needs. And the data we have on healthcare needs in adults indicates that autistic people, for the most part, have higher rates of just about all physical and emotional health conditions. And it's probably not driven primarily by anything specifically related to autism, but the broader social determinants of health. And chronic conditions being related to social connection and lifestyle factors such as healthy eating, opportunities for physical activity and recreation, and mental health. And autistic people often find themselves, often experience disparities in lived experience and in healthcare access. And really thinking about how to improve healthcare for a population of people is really essential to address these needs. So we're really shifting then from thinking about autism as a condition being cared for in a specialty clinic to being a population of people who need good health care. And that health care, like for other Canadians, should be centered in the community within a medical home. And so how do we bridge that gap? Largely, primary health care professionals have been on the periphery when it comes to supporting autistic people, autistic adults and their families. How do we build that capacity, build the confidence and ensure that families feel that they're receiving good care? So that's to some extent where ECHO comes in. Just up front to say that ECHO has its strengths. It clearly is not the sole solution to any of these issues, but I think it does at least bring us together. So I know that many of you are familiar with ECHO from your own reading or actually having a chance to participate in it. I'll talk a little bit about how ECHO came to be and how the ECHO model has been applied to support care for autistic people, specifically related to diagnosis and healthcare delivery, including within our province and where we could potentially go with that. And then to acknowledge some of the opportunities and challenges. And again, I really welcome your feedback as well. I appreciate that many of you have had a bit of a taste of this kind of in your own practices. So ECHO started, it was a bit of a brainchild of a team of healthcare professionals that worked in a chronic hepatitis clinic in New Mexico. They published their initial experience in a controlled clinical trial that was designed for patients with hepatitis C. So, this kind of came to be when they recognized that they served a very large catchment area, kind of covering hundreds of square kilometers. There were patients that had a lot of difficulty making their way into the specialty clinic. So there were missed appointments and difficulty following along with the treatment recommendations. They recognized and respected that they had family physicians who were referring into their clinic were actually pretty knowledgeable. And even if their knowledge varied, they were pretty engaged and committed to providing care. They had a lot of questions and there were a lot of conversations about how to support the care of their patients. So they thought they would formalize it into sort of more of a continuing education community of practice. So they did it as a controlled clinical trial, and they essentially supported the family practitioners in applying the same treatment protocols that they were doing in the specialty clinic. And their primary endpoint was their primary endpoint was the viral response to the treatments. And the bottom line for this study is that the patients that were managed in primary care practices had just as good outcomes as the patients that were being managed in the specialty clinics, with kind of greater quality of care in respect to not disrupting people's lives, not incurring the cost of traveling hundreds of miles, and also there was a sense of satisfaction and empowerment by those family physicians. So the kind of the core motivation for ECHO, this idea of partnering between specialty clinics and community professionals, is that rather than having to drive hundreds of miles or kilometers into the nearest specialty clinic, you can get care with your own physician, or at least sort of within a community health center that's much closer to home. This is sort of the broad principles that ECHO leverages technology. So for me, this was my first exposure to Zoom. I remember going to Albuquerque to learn about the ECHO model. And it's like, wow, you can log online and connect with your colleagues and friends and have these kinds of conversations. And this is like making a cup of coffee now in the morning. But they were a bit ahead of the curve in recognizing that relatively simple technology could be a way of bringing people together. It's a way of sharing best practices. So the focus of these sessions is on sort of the range of healthcare practices for a particular condition, and it's not necessarily the cutting edge research, but rather the day to day, the 90% of practices that's needed to provide essential care for the range of patients. The focus was on professionals in rural and underserved areas, but as ECHO has grown, it actually includes community professionals, even within urban centers. There's also been efforts to reach out to underserved communities that are defined in other ways, like, for example, by ethnicity. The the focus of the ECHO model is case-based discussion, and it's all teach, all learn. So the idea is, in contrast to traditional telehealth, where you might have a community professional presenting to a specialist group, and then the specialist would kind of provide advice directly to that community professional. ECHO really is about bringing together a number of community professionals, where one discusses the cases and then their colleagues actually work together to help flesh out the case and actually provide recommendations. So it's this collective process of sharing and building expertise, where you're moving the focus of expertise into the community and really encouraging the participants to support one another. It's aimed to increase knowledge, and there's a small presentation that's always part of these sessions. And ultimately, it's about reducing disparities. So really hoping that for, thinking about what the experience was for hepatitis C and wondering if for other conditions you could actually reduce the gap experienced by people outside of large urban centers, and also work towards people with health conditions receiving similar care and similar outcomes, whether they travel into a specialty center or whether they work with their own healthcare professionals. I was searching up sort of where the applications of ECHO were in Alberta, because my sense was, as we got started with ECHO Autism, there wasn't a lot of ECHO activity in Alberta, and I was impressed to find, I'm interested if other people are aware of this, that one of the first applications of ECHO was actually specifically around hepatitis C, like just where it started in its inception, and it's out of the University of Calgary, and it's actually a partnership with Indigenous communities. It applies ECHO along with Indigenous learning frameworks. So this, in their paper, they talk about this two-eyed seeing framework, and that building relationships and shared expertise and respect for one another, that's kind of a central component of a kind of Indigenous-led healthcare, was infused into this ECHO as well. And they've kind of achieved relatively similar outcomes as the group in the States, finding that physicians engage, that they have a greater sense of empowerment. Families feel positive about the care that they're receiving. I don't think that they've gone to the same extent in terms of evaluating individual patient outcomes, but they've actually had a somewhat positive start to ECHO. And so this is an application of ECHO specifically with Indigenous communities with a healthcare focus, where they're kind of very similar to the starting point of the original ECHO on hepatitis C. We are now, I think for the past 5 or 6 years, we've had a chance to apply this ECHO model to support care for autistic children. We've done it here at the Glenrose and have expanded within a partnership with the University of Calgary. It relates to our affiliation with the Autism Care Network. And although we've received support from that US-based network and also from Autism Speaks Canada, we're also grateful that that Alberta Health Services and specifically the Glenrose Rehabilitation Center and a number of clinicians have just invested time and resources to make this more sustainable. And a huge shout out in particular to Shannon Ma, who has been organizing and coordinating the sessions from its inception. And I've also included pictures here of people who've led, who've been participants and led the hub team. And I'll talk a little bit more about what that means, but this includes Jordana Hildebrandt, a psychologist, Charlene Prochnow, who's a family-centered care coordinator and leader here, Maureen Rossi, a resource consultant from Autism Edmonton, Adam Kedme, who participates as someone with lived experience. Charlene also brings lived experience, as does Maureen, in terms of kind of their role as parents. And for the last couple of years, we've been fortunate to be working with subspecialty residents in developmental pediatrics. So Rebecca has been co-leading the sessions and actually led her first session yesterday. So ECHO is a hub and spoke model. So this idea that at one end you have a specialty team that sort of kind of comes together to represent the specialty center, and then you have spokes. So essentially, community professionals or multiple community professionals embedded within particular practices who come together to have this community continuing education experience. Discussing cases and talking and having these kind of brief presentations. The format for ECHO, we always start off with introductions. Our group has gotten quite large and we've had to find ways of doing this efficiently, but it's really an integral part of ECHO because it sort of it very explicitly establishes that we're working together as a community, and people want to, the assumption that people want to know about each other in terms of where they're working, what type of practice they have, and ECHO very much is built on relationships as well as technical expertise. The center of ECHO really is a case presentation. So one of the people participating from the community brings sort of, kind of an interesting case that they've seen. And they always prioritize the specific questions or issues that they want to discuss so that they can kind of take that information and use it to apply to their practice. It's a very confidential process, so we're not talking about like the presenting person does not give identifying information. It's not like it's a direct healthcare delivery, but rather it's kind of using the specifics of the case to talk about broader issues that might help inform the care of kind of children and families that are experiencing similar challenges. We go through a round of clarifying questions and then recommendations, and we always start with the folks participating from the community, because I think that as we often experience in our own education, often sort of kind of drawing on our own expertise and providing support to others often sort of increases our own sense of confidence and builds our own expertise. So rather than relying on the specialty team, the community members really do most of the heavy lifting. The hub members, after the community folks have weighed in, kind of give their clarifying questions and recommendations as well. And, it's a bit of an interdisciplinary, interperspective group. And, we come with particular professional roles, but there's certainly some overlap in terms of the contributions that people make. And then there is a brief talk at the end. It's kind of been renamed kind of knowledge burst. But bottom line is that it's like 10 to 15 minute talk. It's not all that theoretical. It usually focuses on like practical take-home things that people can apply immediately into their practice. It may be related to the topic of the case, but not necessarily. There's usually a particular curriculum that we're working through in the block of ECHO sessions, and usually the topics are nominated by the participants, kind of identifying things that what might be helpful in their practice and may not come up spontaneously in the cases. So in terms of how ECHO has been applied to autism care, I'll give three examples. One is kind of the community or primary health care of sort of dealing with the broad range of physical and emotional health issues. The second is supporting a diagnostic assessment and moving diagnostic assessment into the community. And a third is an experience that I had through the Autism Care Network that was very formative for me, that occurred during the pandemic. And it was an ECHO that was targeted not at individual practices, but actually at other autism centers. So, not unlike the Glenrose, kind of other centers in Canada and the US that were receiving referrals, having to think about their service delivery models and how to partner with the community. And it was an ECHO that took place during the pandemic where we were all scrambling to adapt to the service disruption and the unique pressures of the pandemic. And it really emphasized for me the value of having a community of practice. And I have to say, for the ECHO Center development and as well as the other ECHOs that we're involved in, I feel like the hub participants actually get as much out of it as the spoke participants. And as we stretch ourselves to think about the practical challenges across the diversity of situations and cases being seen in the community, we have to dig deep and also kind of think about how we build our expertise and also acknowledge some of the gaps in our knowledge and kind of set our own continuing education goals for ourselves. So I think, like often in professional training, this case-based focus, I think, really moves us along in terms of continuing to build our own skills and enhance our own practices. In terms of ECHO primary care, this was initially launched through the original ECHO network under the leadership of Christian Soul, who's a general pediatrician who works at a developmental center, working with Alicia Curran, who's a parent leader, and Micah Mazurek, who's a research psychologist. And through the Autism Care Network, they conducted a trial that involved 148 participants across 10 sites. So those participants included both the hub teams as well as the peripheral kind of spoke participants. As an observation there, the implication is that the average number of spoke participants at that time was about 10 to 15. It's interesting that our current ECHO actually includes about 50 participants. So we've had to think about sort of expanding this model and thinking about the trade-off between sort of ensuring airtime for all the participants, but also making, kind of being able to offer this to kind of a larger number of people. So this initial ECHO trial had a very specific focus on healthcare professionals. So family physicians, pediatricians, nurse practitioners, and another group in the US called physician assistants, who also sort of train to work in a primary care role. I have to say that our own ECHO has expanded beyond this to include folks working with service providers, so a broader range of healthcare professionals, including speech pathologists, occupational therapists, educators, people working in the school system. And again, I think that's enriched our experience. This particular ECHO took place over 6 months, kind of roughly 2 sessions a month. What they ultimately found was that the participants, so that is the folks working in the community, reported significant improvements in their knowledge and their sense of self-efficacy, like how prepared they were to support autistic kids. The interesting thing is that as a clinical trial, they had to declare what their target outcomes were going to be. So when they started this trial, what they were actually trying to do was to affect change in how these professionals actually practice medicine in respect to supporting the care of autistic kids, specifically in terms of screening for early signs of autism and actually management of co-occurring conditions, including sleep a diet, as well as some common behavioral conditions such as ADHD and anxiety. And interestingly, they did not observe change in screening or in practice management. So it highlights that there's a lot of work to do still in ECHO, that the proven outcomes are more at the level of the participants. The limited data that we have in terms of sort of healthcare delivery, does not actually sort of document sort of concrete changes. I have to say as well that the focus of actually data collection has not so much been at the practice level in terms of sort of what the healthcare professionals are doing and what the families and the children are experiencing. Um, the We're fortunate to have a number of partners and collaborators across Canada. The group in Toronto, led by Melanie Penner, have really been the leaders in terms of advancing implementation and support for ECHO across the country. As part of that, they analyzed the types of questions coming up during their ECHO session and the recommendations that were being made by by the participants on the hub team. And so just to, if you can imagine that we have these sessions, we're fortunate to have Shannon supporting the process. So she's furiously taking notes sort of as we're having these conversations and landing on specific recommendations. And then she sends out sort of like a summary note that includes practical recommendations. We have a virtual drive where we keep track of kind of resources, toolkits, kind of links with kind of practical information that relevant to the case, and that all the participants can access to support their own care. Essentially what Melanie and her group did was kind of track over time the topics that were coming up and the types of recommendations that were being made. So broadly, these were the types of cases that they were seeing, which is kind of similar for us. We've kind of split out diagnostic issues and management issues, but I have to say that the diagnostic and assessment issues do end up coming up, that it's difficult to separate entirely. And often the community participants are actually seeing children in their practices prior to diagnosis. So there may be a suspected diagnosis. I'll just ask people to mute if you're not already muted. Okay, thank you. Just to say that the range of cases that they're seeing is kind of fairly similar to what we do. So here's a brief summary of the types of recommendations. So I have to give them credit for kind of going through their records and itemizing these. So the most common recommendation that they made was accessing community resources and providing that kind of navigational support, just like in a practical way. Like these are services and resources that are out there that you can help the families in your practice access. The second broad area of recommendation was kind of referral to specific healthcare professionals that weren't already involved. Sorry, I'm blocked here. Ongoing, yeah, just sort of ongoing care. Oops, sorry. Kind of around a broad range of areas that sort of range from kind of the sort of core features of autism, but also diet, sleep intervention, fitness, and so on. A lot of the discussions centered on co-occurring emotional and physical health conditions, and specific recommendations were made from that perspective. It's interesting that the sort of less common were about promoting parent and family wellness, as well as supporting patient empowerment and autonomy, as well as sort of support for community assessment. I would have to say that particularly the category number 7 is sort of among the most common types of recommendations that we make. And I think it speaks to how the composition of the hub team and the breadth of professionals that participate in the ECHO may actually kind of shape what the emphasis is. And that's not a big surprise that as you move from groups of participants and a hub team that are, kind of mainly sort of physicians, other healthcare professionals, and you include sort of a broader range of disciplines and a broader range of kind of practice contexts, you actually gain sort of a more holistic approach, perspective on how to support care. And that's for me been one of the most gratifying things about participating in the ECHO in Alberta, that we sort of move beyond the traditional focus, which is like sort of really on sort of like kind of physician oriented kind of mostly about physical health. And as we've done so and engaged with both community professionals as well as kind of a broader range of partners, including those working like with Autism Edmonton and people with lived experience, I do feel like we've been able to gain a more holistic perspective. Um, we're fortunate to be working with Melanie as well as a number of other sites across Canada to actually study how to better implement ECHO. So there are 6 or 7 sites, some that have already implemented ECHO and some that are just getting started. And we want to build on that clinical trial that I mentioned that was led by Kristen Soule by moving the focus from just understanding sort of what it's like for the healthcare professionals to participate to actually seeing sort of what change we can actually affect at a practice level and what that means for children, adults, and families. And it's a mixed method study. It really places a focus on understanding the needs of families as well as the healthcare professionals, developing more practical resources to move from simply empowerment to actual practice change. Kind of a more detailed focus on file review and assessing patient outcomes to make sure that we're actually making a difference, and using an implementation science approach to be able to see how we can spread and scale these approaches. As an aside, we're also really excited to be working with Deepa Singhal, who's the chief science executive, chief science officer with Autism Alliance of Canada. Deepa was recently awarded an embedded researcher fellowship from Canadian Institutes of Health Research to work both with the Alliance as well as with our team at the University of Alberta to really think about how we can scale up these educational approaches within our province and beyond to support community professionals in autism care. I'm going to shift a little bit now. We've been talking about the application of ECHO to kind of general healthcare, so support for children with physical and emotional health conditions, and think about how we can use this approach to empowering community physicians to take on an advanced practice role in autism diagnostic assessment. So this is a paper that was recently published by Kristen and her team. It's called ECHO Autism STAT. STAT is actually an interactive screening tool that was developed by Wendy Stone a number of years ago, kind of focused on preschool children to kind of look for some of the early signs. Kristen and her team has used this interactive tool to kind of give community physicians a bit of exposure to what to be looking for, with respect to diagnostic features of autism. And they've used this measure as a starting point to encourage community physicians to be doing diagnostic assessments. Sorry, I'll just add the findings of the study. So essentially, I didn't have the slide. So they, they worked with 16 healthcare professionals who in turn saw 46 children in the community, 46 children diagnosed with autism. So those professionals were asked to contact the families to ask if they would participate in an evaluation of this ECHO STAT. So 20 of those 46 agreed to participate, and then all 20 were seen by the specialty team for diagnostic assessment. And the diagnosis was confirmed immediately for 19 of those children. For the 20th, it was kind of uncertain, but that child also went on to have a diagnosis. So it's kind of exciting progress. I just realized what my original thinking was around the slide, so I'm going to move along. I'm just going to say that this approach is consistent with the direction that we're going in Canada, kind of recognizing that if we're going to keep up with the number of kids that are being referred, we need to create multiple pathways to diagnosis, including within the community. Okay, so here you can sort of confirm that I'm not just sort of making up all these numbers. So this is kind of a brief summary of what I just said in terms of the findings of her study. So essentially, they found that of the kids diagnosed through the program, almost all of them were confirmed by specialists. They also asked the parents kind of what their experience was like working with community physicians around autism assessment, and the parents had a high level of satisfaction and confidence in the physician. However, there are a lot of caveats. First of all, obviously, only 20 of the 46 who were diagnosed with the program participated. So it's hard to know sort of what made the difference. assessments and whether the experience was not quite as good among the other 26, or perhaps there was more ambiguity or uncertainty in the diagnosis for those other 26. The other thing that's really important to know is that that partnership was limited to children that were identified at the specialty center to have very clear features of autism, and it was also limited to children that were less than 36 months of age. So that is a fairly narrowly defined group. I mean, I have to say it's still a pretty substantial proportion of the large number of children that are waiting for assessment here at the Glenrose. Like, even if we could create a scenario where that subgroup of children were being seen in the community, that would sort of significantly improve access. But we still have a long way to go in terms of a broader partnership. Just sort of speaking from personal experience, we have a number of amazing community partners who have experience with somewhat older kids, and also with kids that may have a less obvious presentation. And if we are able to extend this type of approach to allow a greater diversity of children to be seen, that would further improve access. Melanie, sort of based on her own research, has also commented on the research, kind of the research literature to date around supporting community assessment. So, like studies like ECHO Autism Stat, there's kind of good evidence that this can happen. That certainly community physicians and other community professionals, including psychologists, can be very effective in providing diagnostic assessment. Particularly for physicians, Melanie's conclusion was that ruling out autism may require more expertise than ruling in. So essentially, when the community physician does not think the child referred has autism or is uncertain, there's still a substantial proportion of those children that would go on to receive a diagnosis of autism if they were seen in a specialty clinic. And what that really emphasizes is the need for flexibility between those pathways to diagnosis, and acknowledge that there is greater complexity for the children beyond sort of the subgroup that were included in the ECHO Stat trial that Kristen Soule reported. One of the criticisms of this approach that's sort of being discussed in the field is that often community physicians' assessments is not quite as comprehensive as what traditional autism assessment has been in specialty centers. And in particular, it doesn't include the same level of functional assessment, so cognitive assessment, language assessment, and so on. Within Edmonton and largely in the province, most of the children seen in the community would still have a community speech and language assessment to inform diagnostic judgment. The question of whether children should be having comprehensive cognitive testing, it certainly is really important developmental context to understanding the child's needs. One strategy that Mel has advocated that resonates for me is that to think about assessment as potentially occurring it kind of over time and in sequence, and that perhaps some additional functional assessment might not take place at the point of diagnosis, that we can feel fairly confident in diagnosis in the absence of that more detailed testing, at least for some children, but perhaps that testing should be done sort of kind of right before children are entering intervention programs to make it more timely and more kind of linked to specific service planning. Of course, we know that also doesn't always happen, but in general, sort of having that kind of functional assessment sort of linked to intervention planning may be sort of ultimately more meaningful, and also sort of allows us to unpack and separate out assessments that are needed for the diagnostic process versus services needed to have a more kind of comprehensive understanding of the child's development. In Edmonton and through the Glenrose, we've had our own community physician training model, that was initially led by Lynn Sonnenberg before she kind of moved on to another professional role outside of the Glenrose, and also by a number of clinical administrative leaders within the Glenrose listed here: Carrie Petihecki, Curtis Perot, Shannon, as well, and Laurie Demarier. Um, our training approach, and again, I believe a couple of people on the line have actually participated directly, involves kind of initial, kind of traditional training, sort of working through a diagnostic assessment, not the STAT, but kind of a scaled down version of the ADOS. And during the pandemic, kind of led by Lynn, an interactive assessment that is coached by parents and that can be administered online called the Apples. The second stage is actually for folks like Lynn and I to actually go to physicians' offices and sort of work with them side by side as they see the initial few children that they're seeing for independent assessment, to be able to provide some real-time coaching and help refine their approach. And then we move it essentially to ECHO. So after those physicians have that hands-on experience and where we're physically present, then they come to an ECHO session where they present the kids that they're seeing. And not unlike in the ECHO STAT process, we sort of, Shannon and I kind of work in the specialty center, kind of come up with our own impression and sort of look at the agreement. And generally it's been very, very high. The nice thing about using the ECHO approach is it does create more of a community of practice, and not, and like in other ECHO sessions, it's really the community colleagues that are doing a lot of the heavy lifting in terms of providing feedback around the assessments. This was sort of like a screenshot from one of our assessments. A lot of great people in town that have been involved, including Hasu Rajani, who's the clinical and academic lead for general and community pediatrician, has really kind of championed this approach. It's been great working with Georgetta Apostle in the top corner, and her colleagues at the Royal ALEC who've been looking at implementing this in more detail, and Eddie Bolster in the lower screen, who's been working on this at the Stollery. I want to acknowledge some of the challenges of community diagnosis. Community docs have been pretty busy the last few years at a number of levels, and these assessments, even sort of when they're adapted for a community setting, are take a fair bit of time and resources, and take a bit of problem solving how to integrate into a busy practice. Our experience, particularly working with the group at the Royal ALEC, has been recognizing that even as physicians gain the skills and confidence to do the actual assessment, the other practical aspects like reviewing the file ahead of time, drafting the report, sort of dealing with Connect Care related issues, and then helping the families kind of through processing the diagnosis and then as navigating and obtaining services, does take a lot of time. And so working through a process improvement process of sort of streamlining that, being efficient, making sure that they can manage this within a busy practice becomes really important. And again, to acknowledge that this work primarily focuses on preschoolers at this point. I want to briefly talk about experience now, sort of rather than working with individual professionals, kind of working with other developmental centers. And for me, this is like really exemplified sort of what it means to become a community of practice, and to be thinking about a community of practice, not just in your individual role, but thinking about how you represent a practice or a developmental center. So this started up during the pandemic. I'll just sort of anchor this in a kind of a reflective paper that was published a couple years ago, led by a qualitative researcher who worked with the Hub team, that was included Kristen Soul and myself and a number of other professionals who had experience doing echoes at their individual sites, but had never quite experienced anything like this, where rather than working with community colleagues, they're essentially working with kind of people who actually had very similar clinical and leadership roles in their, at other centers. So again, and this is a bit wordy, but I want to kind of hit the key points that it was during the pandemic. And the participants, like the spoke participants, were really folks that had clinical leadership roles at large centers. And so it was less about, kind of how to take a diagnostic history or how to manage a sleep issue, and more about, well, how to transition to online assessment, or how to manage a large wait list, or how to actually build partnerships with parents and community. And in the course of this ECHO experience, all of us on the Hub actually basically kept a diary of sort of what this was like, because none of us had done anything quite like this before. The main conclusion that came out of this was that ECHO as applied to this context, really cultivated a learning environment that shared learning and acknowledged the expertise of all participants. And, sort of this all teach, all learn, which is a kind of central principle of the ECHOs. I think another thing that occurred to us is that, the profound impact that participating in an ECHO as a hub member has on our own perspective about autism care. So there's a lot written about leadership, and often we find ourselves in leadership roles, not necessarily by design, but just there's so much work to do. And we're rarely working in isolation. We're working as part of teams. We're working at centers like our practices, in the school system, kind of in with FSCD service providers, and in a place like the Glenrose. And we need to kind of reflect about how we approach our roles as leaders. There's, oops, sorry, just getting my ugly picture out of the way so I can see this. Some of the key principles of adaptive leadership. So adaptive leadership has been formulated as a way, not just sort of dealing with technical issues, but responding to complex system level challenges. And we certainly faced that during the pandemic. And arguably, we continue to face that at a time of lengthy wait lists, complex political dynamics, difficulty kind of in a strained service system. The principles of adaptive leadership are shared responsibility, an emphasis on considering alternate perspectives, and supporting an ongoing cycle of analyzing problems, trying new approaches, as well as self-reflection. So this isn't about simply kind of prescribing and getting and sort of kind of too anchored in one approach and doing it ad infinitum without sort of critically evaluating it, but actually have the flexibility to be adapting and changing along the way. It occurred to us that that in our roles, the ECHO participants gave us the feedback that they felt encouraged to approach their own approaches in a similar collaborative fashion with their own community partners. So in a sense, the participants were also, they were also leaders in their own right. And, it's not true just for the center development, but I think it's true for all the ECHOs that everyone participating, they play mentorship and support roles and leadership roles in their own community. And what we felt was that accessing a safe space to learn and receive constructive feedback, as well as mutual support from colleagues, and colleagues who actually get it in terms of facing similar pressures and uncertainties, it not only helps our professional practice, but it actually promotes our kind of personal, kind of professional development and wellness. It promotes resilience and encourages us to think in a flexible way. And to some extent, it buffers us against burnout, because we're all kind of in this together. And that's a bit of a pat line from the pandemic, but it's true that working in a complex environment, it's great knowing that you're not alone. And that, I have to say, that's what I love about ECHO. So bottom line, ECHO is a simple but powerful way to share knowledge, build capacity, and establish a community of practice. It allows specialists to support care of their own centers. And I think for all of us, it's important to reflect, how do we have the greatest impact in our professional roles? Some of it is about working with individual families, but if we can support and empower our colleagues to expand their practices, our influence can only grow. ECHO's nice because it's a relatively low resource strategy, but it's not a no resource strategy. And I think we continue to have to work to think about how to make this sustainable. It definitely has broad applicability. There are places that have sort of offshoots of ECHO Autism to focus on the school system, supporting parents, supporting particular communities. But it's not a be all and end all in terms of a continuing education strategy, and sort of other approaches are needed as well. Especially through our experience here, it's a great opportunity to infuse lived experience into care practices. And again, it's also pretty fun, and it's been a great learning experience. But it's certainly a work in progress, and I welcome your feedback. So thanks to everyone. I realized I just sort of dropped my thank you slide, but thanks everyone who's been involved in ECHO, everyone who supported this process. And yeah, I'm glad we have a little bit of time for questions. Thanks, everyone. All right.
For that great presentation, Lonnie. I'm just going to hit stop record before we move to the question period.